Trainer, Associate Dean of Faculty Development in Academic Affairs Office here, and welcome to our first Primetime session of the semester. It's hosted both by Faculty Development and Friends of the Library, so we're very appreciative of Friends of the Libraries providing both the library providing the space and Friends of the Library providing food and drinks, so that's great. We are adding this year, pretty much every Tuesday we'll have a ready for prime time, or for someone who's still working on a project, they're not quite ready for prime time. We also have some of our Edgren scholars presenting this semester, and then we've added for the first time, kind of in this format, on Thursdays, at least once a month, a talk about teaching. Because a lot of the Tuesday sessions have been very focused on research and scholarship, which is great, but we're also really committed to teaching, so we're adding some of those on Thursdays, so please watch for those. It's my pleasure to introduce today Marge Shaffer from the nursing department. She's been at Bethel for 25 years and done amazing work in research and scholarship and with teaching during that time. The work that she's going to present us today comes out of her Fulbright that she had in Norway. So, Marge?
Okay. Well, thank you very much for joining me today. And what I plan to do with my time there we go. Okay. I'm going to share with you my Fulbright journey, talking about the research that I did in 2005 on end-of-life decision-making with for Norwegian elders, and then share some of the nurses' stories that came out of that research that I published in a book that came out in July, and then also share some of my current Fulbright experience that I've been involved in at Econova University College. So, in terms of my research, my whole idea was to explore the problems, ethical problems encountered in end-of-life decision-making for Norwegian elders. And so I interviewed healthcare professionals, elders, and family members. Originally, I set out to do the research in institutions in Norway, nursing homes, hospitals, but I very soon realized that that required a very extensive human subjects proposal, IRB, Institutional Review Board. And with my lack of knowledge in Norwegian, that would not work so well. And so I opted for a community level, which meant I could interview people in the community that gave their consent, as well as health professionals. And that worked quite well. I still had to do an IRB in Norwegian, but I got some help from it, and it was much less complex. So what I did, I used kind of a framework that looks at getting the views of everyone. It's called the community contractual model. And so in terms of what influences decisions at the end of life, this includes the individual, of course, but also family members, the healthcare professionals, the institution, and then society as a whole has ethical standards and laws, usually, that are related to end-of-life kinds of decisions. It's interesting, in Norway they have no legal advance directive, and they have universal health care, so I was very interested in how that impacted what happened. And malpractice claims are very rare, so it's a different environment. So the kinds of questions that I asked all three groups about how their decisions were made, how decisions got made. I asked them what conversations, who they talked to, and what they talked about. I asked them about their spiritual concerns at the end of life. I asked them about their worries, their concerns, their conflicts that they had. And I asked them what they thought should be different about end-of-life care. So I did my interviews in Oslo, outlying suburbs. I went to Bergen for a week, and also up to Tromsø, which is pretty far north. In April, we had bright sunshine at 4 a.m. in the morning. I had all sorts of modes of transportation. I did a lot of walking, but also taking the T-Bahn, which is like a subway, taking the Trick, which is like, with the, what do you call that thing going overhead, and the buses and trains and all sorts of things. So I had lots of adventures. Fortunately, there was a wonderful website there that I could use, something like MapQuest, that could show me exactly how to get there. So I really used that quite a bit. Okay, so what did I end up with? I had 25 healthcare professionals in my sample. Most of them were nurses, 17 nurses, 4 physicians, 3 ministers, and a social worker. The elders were 2 men and 4 women. And although most of my stories today are about nurses, I just want to share a couple with the elders. One of the questions I asked them was about their health, because that can certainly impact the decisions you make at the end of life. And so an elderly gentleman, over 80, said that, well, he was in good health, except that he had broken his leg skiing the year before. So I thought that was very impressive. And then an elderly woman was just so grateful to be able to talk about this topic. She just said over and over how much she really enjoyed talking about end-of-life decisions, because she could not get her family, her sons and daughters, to talk with her. So she was just very appreciative of the opportunity to do that. And then I also had 5 family members participate. They averaged about age 54 and had had a recent parental death that they talked about. Now, I didn't have any difficulty getting people to talk to me about this really kind of sensitive subject. And so that worked very well. However, the professionals were very, very businesslike. And so they would give me the interviews, but then that was all they wanted to do. No more talking. It was time for me to go back and do what I ever needed to do, and then they need to go on with their work. So I think that's kind of different from the experience we might have here. So for the health professional ethical problems, I had 25 health professionals. They identified a total of 94 ethical problems. Most of them had to do with interactions with families. And that is fairly comparable to what's found in the literature, too. A secondary was quality of healthcare services. A third area was disagreement, not being on the same page about decisions that should be made. And for elders, they were worried about getting too much treatment. They were worried about being dependent on others. They used the word, they didn't want to be a burden. They talked about being a burden. They didn't want to be a burden to anybody. They also worried about dementia and not being able to make the decisions. And they had not talked with their physicians about what they wanted. That just did not happen. So that was interesting. Family members, most of their conversations had to do with worrying about getting good health care. And there was really some anguish about the experiences that they had had trying to get good health care for their parents. And so that was a topic that I heard most of the time. They also did not know how to talk to their elderly parents about end of life or about spiritual issues. That was a very hard thing for them to have conversations about. So when I had all these ethical problems to analyze, I did a comparative analysis across the 3 groups. And these were kind of the 4 themes: quality of healthcare services, and treatment was certainly available, very much available, but palliative care as a philosophy of care was less available. There's actually in the hospice that I visited and did an interview in, a 14-day limit. And the hospice stay limit, so after 14 days you would have to leave. And it was mostly focused on patients with cancer, so there was not much available for elderly patients. In fact, one of the ethical problems for the nurse there, the nurse who was the coordinator manager, was that she would receive many phone calls from adult children wanting to get their elderly parents in, and there was just no room. And so that was one of her big concerns. In terms of interaction among family members, the elders were concerned about burden, but the family members never brought up that word. They never perceived their elderly parent as being a burden in terms of working out end-of-life care. Talking and planning for death was another theme. There was quite a reluctance to talk about death, quite a respect for privacy, which is very cultural. So it was hard for everybody, even though they talked to me in the interview, with talking with each other when they were talking with family members, that did not happen very often. In treatment decisions, they talked about being uncertain, not knowing when the time has come. When do you start deciding that it's the end of life? They talked about too much treatment. And as I did the interviews, I realized that the physician is really viewed as the final decision maker. In fact, a major goal of Norwegian health professionals is that they want the family to have a good experience and not feel like they've made a wrong decision. And so it's almost rather a paternalistic point of view, I found, in comparison with my own American culture, that they wanted to protect the family and not have them feel responsible before any decision. So sometimes they kind of made the decision for them or didn't always give them all the information. And they would do whatever the family wanted. If the family wanted the person transferred from the nursing home to the hospital, even though it would do no good and it was futile, they would do so because that's what the family wanted. So, implications for practice. I think more recognition of when the time has come, and actually, that's a phrase the Norwegians used, when the time has come, so that's where that comes from. I think there needs to be more dialogue between health professionals, and certainly some development of communication guidelines for working with family members. And I think one thing that could be integrated more is a palliative care philosophy. They certainly have a few hospice and palliative units, but integrating a palliative care philosophy more throughout their healthcare system. Advanced directives, like we have in the United States, are not consistent with Norwegian culture. So I couldn't say, well, everybody should have an advanced directive. That would not work in Norway. And so one needs to find ways of working that are within the culture of the system. And so I came back and wrote an article for Nursing Ethics on that research. And as I was reflecting on that research, I thought the nurses' stories are very meaningful and very important. And I just kind of felt this, this passion and this urge to really get those stories out there, more so than it had been in my article. And it really planted a seed for actually writing a book. And so I contacted Linda Norlander, who I had talked with before I had gone to Norway. She had had several publications related to end of life, and had worked on a project on end of life in Minnesota. And she'd also done some other writing. She published a detective novel and short stories, so I thought, here's someone that kind of knows about publishing and writing. So I met with her, and we then submitted a proposal to Sigma Theta Tau International, who did accept our proposal. We added a focus group. We decided to do a focus group with American nurses. So we pulled together some nurses in the Twin Cities area, the metro area, that had lots of experience in palliative care, so we could kind of add some more nurses' stories to that book. And the book was actually published last July, so here it is. And if anybody's interested, I have some cards right down there that tell about how to find the book. So what I'm going to do now is share some of those stories that I found so very meaningful. And the first one I would like to share, I think really was one that rather inspired the book for me. And this was for a Norwegian nurse who worked in a nursing home. And what she said, I had heard about those golden moments when the patient starts talking about something that is important or difficult to him, and you just don't listen, or you just don't know what to say, and later you think, oh, I missed that moment. She said, I've learned after all these years that you have to make this golden moment, even if you don't have the time. Like the day when an elderly man said, I can't talk to my wife. I need to speak to her about the fact that I'm going to die. I was very busy, and afterwards I felt bad. When you are younger, you think this moment is precious, and when it's gone, you can't get it back. But this is something I try to tell the young nurses. You can go back, and you can make those golden moments come back. And so that's what this book is all about, creating those opportunities for communication that can help patients and families with that end-of-life journey. And my co-author and I, Linda Norlander, really wanted to call the book Golden Moments. We just love that metaphor. But of course, when you work with editors, they had some reasons why that might not be so good. And they're probably right. It kind of maybe signifies to most people it's elderly people, and it's really across the lifespan that we're covering. So we had to let go of our wonderful terminology, golden moments. But I like being present really well, so I think that works pretty well. So these are the communication themes. So the way that we came up with the chapters for the book was to look at the nurses' stories that we had, and it actually started with the Norwegian nurses' stories, and identify major themes that were important. And they were being present, knowing what to say and when to say it, responding to patient and family wishes and hopes, understanding the spiritual journey, responding to conflict, and then advocating when the nurse needs to take action, and saying goodbye. And we did add a few other chapters in response to reviewer comments and then also the editors, but these were the ones that really guided our book. So I'm just going to read a few of those stories that represent those themes. And the first one is about being present, actually, and what it means to be present. And sometimes being present means not saying anything, being silent, not filling up the space. And so this is about that. The oncologist stood at the foot of the bed and talked down to the patient. He explained in highly technical terms all the treatment possibilities. They would add TPN to his regimen. If he had trouble breathing, they would intubate him. They would monitor his potassium level and so on and so forth. So it's all about the specific treatment they're going to do. The patient's wife listened attentively. After the doctor finished his speech, she asked, "Any questions?" No one said anything, so the doctor left the room. After he left, I sat quietly with them for a few moments. After a minute or two of silence, I asked, "Do you understand what's going on here?" The wife looked at me with tears in her eyes and asked, "Does this mean he can go home? He really wants to go home." This was what was on her mind. This was what, she needed to be thinking about and talking about. Ever since then, I have been very aware of how easy it is for us to put up a barrier in difficult situations by using technical terms and by lecturing rather than listening. And so I think by being present, it means being open to the patient's experience through just being there and listening. And this nurse did that and really realized the patient's experience. Then I have a story from a Norwegian home care nurse about knowing what to say and when to say it, especially when there's a fear about bringing it up. It's a sensitive topic, and so people are reluctant to bring it up. And sometimes people think the other person knew something, doesn't know something, and only they know it, and they haven't talked about it, so they don't even realize what they each know. So this is her story. I've also had situations where I've spoken to relatives who won't discuss it because they don't want to depress the patient. So you talk to the patient alone, and the patient says that his wife won't discuss it. When you talk to her alone, she says that he doesn't know that he's dying. Frequently happens. Then I've actually gone in and convinced everyone to sit down and discuss it. I've started a conversation with the patient with the point of view of asking him to be honest with himself. I ask if he feels perhaps that the situation is a little more difficult than the impression he gives. If I feel I can say that, which in this particular situation I did, everybody started talking. It was very difficult for the wife to hear it because she was in shock that her husband realized how ill he was. But in a way, he made things much easier because then she could start talking to him about where they were in the situation. And he died much more relaxed. So what a great outcome from that piece of communication. It didn't take a lot, but it just took being there, being sensitive to the patient's experiencing, realizing what was happening, and giving them a little open door to go through. And then everybody started talking. Here is one involving a cultural issue that is about responding to patient and family wishes and hopes. And there are very different views related to culture in terms of how people respond to wanting to know what's happening or telling families. And as for nurses need to recognize that all don't have the same view that they do about end-of-life communication. And so this nurse said, this is a hospice nursing supervisor. I was supervising a hospice program and got a referral for an elderly Southeast Asian immigrant. The children requested that we not talk with him about dying. Staff members were in a quandary because we require a signed consent to begin hospice. As we discussed it in our interdisciplinary team meeting, we decided that family could be proxy for the consent because individual autonomy was not a cultural norm for them. We cared for the patient throughout his end-of-life journey without using the word hospice and discussing dying with him. When he died, the family thanked us for our care. Also in this story, you can see the importance of the interdisciplinary focus. A lot of the stories involve working with people in other disciplines, physicians, social workers, of course, families. But how do you work across the disciplines to all have a similar approach and recognize what the patient wants is very, very important. Then there's a story on understanding the spiritual journey, and this one was difficult for both Norwegian and American nurses. Hard for them to know how to approach, and especially for the Norwegian nurses, I think it was most difficult. In Norway, every healthcare organization has their own minister. The term they use in Norway is priest, all provided by the state church, which is a Lutheran church. And the ones that I interviewed, the 3 that I interviewed for my initial study, were very caring and just had the most beautiful language for how they worked with patients at the end of life. But nurses, other than one nurse, and I think it was a nursing home, which had kind of a Christian foundation and philosophy. And she talked about how she journeyed with the patients at the end of life. And she actually sang one of the hymns that she sang to the patient, and that was quite lovely to experience hearing that. But this is a story about reconciliation and forgiveness, which is a very big part of the spiritual journey at the end of life. And this was a hospice nurse. We were trying out this new assessment form called suffering assessment. I didn't want to ask him the questions because I thought he'd be gruff and tell me this was stupid. So I gave him the form and said he could fill it out if he felt like it. He read it, and when he came to the question, how much are you suffering due to personal and family issues, he marked down a 10, the most suffering possible. When I asked him about it, he told me he had lost touch with his son and wanted to see him again. I think he needed his son's forgiveness. And so I think one of our roles is for nurses who are working with patients at the end of life is to help them to try and reach out for family members that they have not seen in a long time, and to really get that that opportunity to say goodbye and to ask for forgiveness, I think is a beautiful spiritual thing. Of course, there can be a lot of conflict in end-of-life care, end-of-life decision-making, and the conflict can occur with patients, with families, between professionals. There can be ethical conflict, so there's actually many types of conflict. And I'll read one of the stories about responding to conflict. And this is a palliative care nurse who wrote, the patient's healthcare directive was eloquent. She said that dying was a part of life. She was no longer alert and not able to make decisions. What do you do? Tube feedings? I pulled the 3 daughters and the son-in-law together. One of the daughters said, you have to put in a feeding tube or she'll starve and we'll be killing her. I read the directive out loud to the family. It very clearly delineated no CPR and no artificial feeding. The patient said in her directive, I don't know what I might be dealing with, but I don't want to be resuscitated, and no feeding tube. Look at my quality of life. I'm okay and ready to go. These are tough decisions, but I am taking the burden from you. I told the family that we would not put in a feeding tube because it was against her wishes. It would be unethical and illegal. I turned to the daughter and said, I'll get the priest, I'll give you the support you need, and we'll keep her comfortable. She died the next day. The daughter was not particularly happy, but we honored her mother's wishes. And she went on to say, I usually try to bring in the directive and say, this meeting is about what your dad wanted, and he can't speak. I say, if he could speak, what would he say? Families sometimes say, well, he'd say, forget this. So giving that opportunity to reflect on what the person who's dying would want. And then, of course, advocacy, very important role at the end of life. And this is a home care nurse. And sometimes in these very difficult situations where it's challenging to communicate with people, we often operate under assumptions And so this nurse really worked through the assumptions to advocate for this particular patient. We'd had this patient on and off in our home care program many times. She had a history of exaggerating symptoms, and her doctor had labeled her as an attention getter. After hospitalization for shortness of breath, she was referred back to us. The social worker and I went out to see her, and she said, I don't think I'm doing very well. Well, we could both see that she had changed and that she looked very sick. When we asked the doctor for a referral to hospice, the doctor refused. She needs to be on her psych meds, and she'll be fine. So just making an assumption about what was wrong with her. We both disagreed and finally ended up in a heated discussion with the doctor. We said, we believe the patient is dying, and the patient says she is dying. So we're really listening and believing the patient. Reluctantly, the doctor wrote the order for hospice. The patient died 10 days later at home where she wanted to be. Much better than worrying about the psych meds at that point. And saying goodbye is also important piece to give people the opportunity. Sometimes they don't want to say goodbye, and so we need to accept what patients and families want to do. But I think we can give them opportunities to say goodbye. So this story is about that. Right now, we have a patient who receives artificial intravenous nutrition, and it makes her very sick. She dislikes it, and she tells the nurses and the doctor that she feels she must do it because of her husband, because he's not prepared, and he needs more time to understand the reality that she's really dying. That's just a very interesting concept that I think that happens over and over. Patients who are dying feel that they need to do this for someone else, even though they don't want to. So if we can have that conversation about that, maybe it can help them work through the decision. This is something we are very much aware of about the process. It's an art, and we don't always manage, but we try. We're asking questions to make sure they come to some sort of conclusion. And we must not just leave it, that not all patients here come to the point where they're ready to give up treatment or ready to say goodbye to the relatives. I think that is the strategy, to walk with them in the process and not to tell them what it should be. And that's quite a lovely, lovely statement of being present. Walk with them in the process. And I have one final story, and then I'll share a little bit about my current experiences with Fulbright in Norway. This is one of my favorite stories. I really like this one. It is about kind of the meaning and purpose and end-of-life care, even as challenging as it is, the rewards that come from that. And so that is actually in the final chapter of my book. And I do want to read, too, before I read that, the dedication in my book, and kind of the reason, or what I hope it will mean, what it will mean to people. So, the dedication, we said, we dedicate this book to nurses across the world who care for dying patients and their families. It is through your work that living the end of one's life has potential to be a whole and holy experience. We hope that each of you continues to receive the strength, the rewards, and the inspiration to continue this work. And so this is a story of inspiration. It's about the grandfather and his grandson. The grandfather was a depressed man who was just wanting to die. After having a discussion with his wife, daughter, and grandson, I realized that the grandson had been really close to his grandfather. When the boy visited his grandfather, though, the boy would just cry all the time. It was difficult for the grandfather. He complained, and one time he said, "Oh, just take that kid home." It sounded like he didn't want to be there. He sounded angry. After I talked to the family, I realized that it didn't have to be like that. So before the wife and family came back in, I talked to him about the grandson. I said, he's just a teenager, and I told him that it was difficult for the boy, and he needed to be there even though he had cried. He needed to be there. The grandfather didn't respond to me, but when the boy came back into the room again, the grandfather opened his arms and said, "Come here and sit by my side. I have to tell you how I love you so." They had so much together, fishing, mountains. This gesture and this gesture from the grandfather helped the boy to be okay with his coming loss. We cried watching them, and later that day it was much easier atmosphere in the room. When the boy left that day, he said, "Love you, Grandpa. Come back soon." And that's the way they had talked before. I think it helped this boy for the rest of his life. He is going to live on, and he was able to share with his grandfather what he felt. What a wonderful experience for this young grandson, and for the nurse to be able to see that happen. Again, just a little small intervention with huge, big results for the meaningfulness for this family. So that is just, I think, a wonderful story. So transition a little bit more to my Fulbright experience currently. I just, in October, spent 2 weeks in Oslo at University. And one of the things I did was to bring my research back to present in Norway, which was just a joy. And when I got done presenting, one of the nurses in the audience, it was an International Public Health Nursing Conference, came up and said, "You told my story." She was actually in my research. And that had to be very meaningful to her. So that was a lot of fun, very much a lot of joy in that. And then the other thing we did, my colleagues Sandy Peterson and Barb Hoagland came to Norway for a good part of that 2 weeks, attended the conference, and we worked on partnership planning with University. So that really has grown out of my initial Fulbright in Norway. I went to to present the Public Health Nursing Intervention Wheel, and it was something that they really enjoyed. It made sense. They wanted to put it in their curriculum. So we've had conversations along the way, and they now have invited us to participate in a partnership, and so in the future we will have student and faculty exchange and maybe some collaborative research. So that is really, really exciting. So one of the pictures you see on the slide with Barb Hoagland in, and Martin Brunman is the rector, I think kind of like a dean of nursing or something like that, myself, and then Sandy Peterson, and then Ragnhild Nordahl, who is the director of the undergraduate program. And then the picture on the bottom there is a picture of the hospice, the Louisenberg Hospice. So we did some site visits, went to Louisenberg Hospital, and then Louisenberg Hospice. And it was just a beautiful building inside, and lots of bright colors, and lots of care, and really a good environment, a peaceful environment for people who are dying. So wanted to share that with you. Fulbright opportunities are just, I just want to share those with you because I would like everybody to think about that possibility. And there are also Fulbright opportunities for students when you graduate and maybe go into master's programs abroad. And so when I was in Fulbright in '95, we had a whole Fulbright group of scholars and students who were there. And it's actually 2 of the students that I still have contact with because of our, we go hiking together, we go to museums together, and go skiing together, go to chocolate factories together, all those kind of fun things. So I still have contact with 2 of them. But Fulbright sends 800 faculty and professionals to other countries each year. And it's both lecturing and research. It can be all one or a combination of those. And then the Fulbright Specialist Program, which I'm currently involved in, allows grants for 2 to 6 weeks to go short-term in specific disciplines. So I'm in the public health discipline. This is a program in over 100 countries. And it's to do consultation, short-term lecturing, conferences, curriculum planning, that kind of thing. This one is not to do your own personal research. A scholar program, you can do your own research. And so I applied to be on the roster, and I'm on the roster for 5 years. And so I went to Norway in October for that, and I'll go again in May to continue with the consultation on their master's program. And then I can go one other place too. I do have to be invited, but also if you have connections, you can kind of say, would you invite me? And what you can do. So you can do that kind of thing. And then lastly, I would just like to share these two websites. Whoop, go back. The Fulbright website. Gives you a lot of information about the programs and criteria for applying. And is it not going to come up? We'll get there. But anyway, I have to tell you, at noon today, it opens for the 2011-2012 applications. So, and it will actually tell you how many days, minutes, hours and minutes that you have left to apply. I think it's in August. Okay, I guess it's not going to go bigger. But if there we go. So if you look here, August 2nd deadline, 180 days, 12 hours, 7 minutes, and seconds are counting, okay? And we do have a couple people here that have had Fulbrights. Bernie Missel went to Amman just last semester, so you can talk to Bernie. And Karen Drake, over there, back there also, has gone to Uganda, and she's had both a Fulbright Scholar Award and a Fulbright Specialist. So these are people you can talk to. Jay Rasmussen from Education received a Fulbright, and he also went to Norway. So he had gone before I did, and so I had a lot of conversation with him about okay, then I want to look at this one last website. Should come up in a minute. And I think there's somebody from the psychology department, too, that had a Fulbright. Carol, do you know who that is? Fairly new faculty member, I think.
Did Adam John?
Yes, I believe so. I believe so. So I would really just encourage you to look into. It's just a marvelous opportunity. Okay, so this one is my Fulbright story that's on the Norway website, and I just have to tell you about that picture. One of the benefits that has come out of Norway is my developing relationships with a couple of faculty at Diakonova University College. And Kari Glavin and Elizabeth Carmi actually came here in October of 2008 and spent 6 weeks in Minnesota. I connected them with the University of Minnesota because they're both working on their doctorate degrees, PhDs, close to being finished. They have to write they have to have 5 published articles in order to get a PhD in Norway. It's very, very rigorous. But they came here, and so we were able to do all those kind of fun things. They came to my church a couple times. We went on a hike, and we did this is the celebrating Canadian Thanksgiving. And so we're all dressed up in our Voyager clothes in a big canoe and going down the St. Croix River. And so this last time when I went back to Norway, with those friendships established, was very different than my first time. I felt kind of alone my first time, a lot of the time. Had a lot of activities with the Fulbrighters, but not so much with Norwegians. Whereas now, I had several invitations to homes, and it was quite wonderful and quite delightful. So, very positive experience, and I encourage you all to think about the Fulbright opportunities and look into it. So, I think that's it. I don't know, do we ask questions?
Yep. Yes.
Okay. Anybody have any questions or comments?
Actually, I just want to add, for students that are interested in Fulbright scholarships, they're on a different cycle,
right.
And that's always an October deadline.
Right.
So if you are a student and interested in applying for one, or know of a student, then they can see me.
Good, good. And those are a minimum of 9 months, whereas for the faculty, they can go for shorter periods of time. I went for 4 months.
How did you choose the people you interviewed?
Oh, the help, all by kind of referral. And so I started with faculty at the University of Oslo and asked who I should talk to. And then sometimes when I talked to someone, it was kind of snowball. They would give others. But often it was just getting a name and calling them up and asking them, telling them who I was, and just about everybody said yes. Yeah, and the elders were people, I had to go for the community, so people that knew people. For example, Esther Tatley is a retired school nurse here, and she had cousins in Norway, and so they were elderly, and so they were a good source for me to talk with. With a couple of the elders, I needed an interpreter, but most could speak English pretty well. Next question.
You mentioned that the elders, one of the fears they had or worries was being a burden to their family.
Yes.
And yet they don't have advance directives to say what they would prefer to kind of make those decisions ahead of time.
Right.
Are they aware of that system here and that it would be possible to make those decisions, but it's just so culturally against?
It is. They have something called a life testament, which is that kind of, I want comfort care, I don't want all the invasive care, but it's not legally binding. So some people have that. So yeah, it's just not part of their culture. Like malpractice is not a part of their culture. So it's not, they're very much community oriented and not so much the individualism, but the good of everybody, kind of the common good. Everybody makes a living wage there, whether you work in child care or fast food, everybody has a living wage. And you don't have the big income gap that we have here. I think their occupation in World War II led to a lot of social programs. Yeah, we didn't experience the same thing here. Any other? Thank you for that question. Yeah.
Why Norway?
Why Norway? Oh, I have always been asked that. Okay, so there are really two reasons. One, just the universal health care. I was very interested in that. The second is my heritage is 100% Norwegian. And so I actually found grave sites of my ancestors there. It was quite delightful. So that was a joy to be able to do that. And it's kind of interesting. When I went there, until I opened my mouth, everybody thought I was Norwegian. But I remember the very first day, standing to get the T-Bahn downtown to Oslo to go to the Fulbright office, and someone coming up to me, and it was they missed one. Usually they never miss one, but there was a whole bunch of people standing there. And he started talking to me just like I was part of the group, but it's because I looked very Norwegian. But, so that was one reason. And it helps me to understand a lot about my family and why they are the way they are. So that part was very rewarding too. Yeah?
Are they hoping to increase their hospice care? More hospice care?
There is a group in Norway, and there's a couple of physicians. It's called Dignity for, I think the elderly, or Dignity for something. They are really trying to focus on getting more emphasis on palliative care. So I think they're hoping to develop that a bit further. So they're bringing a whole big conference together in Bergen. And I went to one that they had when I was there, and they brought experts from all over Europe to talk about how we're going to, what are some ways we can deal with this. So that was a great experience too, going to that conference.
You mentioned that one of the concerns of the elderly was whether or not they would get quality health care. Is that peculiar to older people, or is that part of the healthcare system, that it's not always high quality?
That's a good question. Healthcare is very, very available there. And I think it was, I didn't hear it anywhere else for other age groups that there was an issue, but then I wasn't asking those questions. Also, Norwegians tend to be very healthy and live a bit longer. Sandy? Yeah,
one of the areas in which the nurses from the University College that we were interacting with were critical of their healthcare system was the nursing homes.
Yeah.
And so care for the elder, there didn't have as many good choices at when they were no longer able to be at home or nor appropriate for the hospital. So that was, if they would criticize their system, that would be the point at which they criticize it.
Right.
That quality of the nursing home care was something they wanted to work on.
Right.
So is that a resource allocation issue, or is that a cultural issue?
I think it's a resource allocation issue, yeah. Yeah. They've got lots of money, oil money, but they're saving it for a rainy day. I think that's more of the philosophy.
I mean, I was going to say, but it is decisions.
I mean, it's all
because
It's decisions.
Because they pay, for instance, those 5 articles, faculty members get paid for that,
Yeah.
for publishing
Well,
those articles.
the school does. The school gets
yes,
paid every time.
But there's payment, yes.
Wouldn't that be
there's payment
nice?
for it.
Our school got
Yeah.
paid every time we publish an article.
So it is a decision about this pool of money, how to use it, and it's not currently, I guess, being used. It's yeah.
I think the other area of
Because
concern
they
is
spend money.
responding to diversity. They're getting quite a big, and this is very hard for Norway. They're having a very difficult time responding to diversity. And so one of the hospitals we visited in Luxembourg was very concerned about meeting the needs of diverse groups. And so they're seeing more health problems related to that and worried about how to meet them. So I think, elder care and diverse care for diverse individuals, are probably their challenges.
Well, I see we're at 11 and slightly
Yeah.
past, so
Yeah.
thank you very much, Marge.
Thank you.